Hi, it's already 3 p.m., so we will start our session today. So welcome back everyone to our College of Physicians Malaysia. We are starting off, this is the first week for November. We'll start off with the dermatology series. So we are honored to have Professor Dr. Adawiyah Jamil here today as our chairperson. So she is currently associate professor and consultant dermatologist in UKM Medical Center. She's also the head of program of our advanced master of dermatology in UKM. And she also actively participate in the development of our local CPG, especially psoriasis. So without further ado, I'll pass over to Prof. Dr. Adawiyah.
Thank you very much, Dr. E, for the kind introduction. I'm very happy to be here today. Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera, everyone. I think it's very timely that we have this lecture on psoriasis today because I think most would have known that the new psoriasis CPG has just been launched last month. So today we have Dr. Lim Joanne, who is a dermatologist and medical lecturer at Hospital Pakar USM. Dr. Lim Joanne earned her first degree from USM in 2010. So if you think she looks young, she is young. She has a diploma in dermatology from the Australian Institute of Dermatology in 2013, MRCP UK in 2016, and she completed her advanced master in dermatology UKM in 2025. She has participated in multiple research projects and clinical trials, and she has published in various reputable journals, including local and international. So without further ado, I would like Dr. Joanne to deliver her lecture.
Yeah, thank you very much, Prof. Adawiyah, for the kind introduction. And also, I'd like to thank the Academy of Medicine for the kind invitation. So let me just share my slides. All right, is my slides visible?
Yes, we can see it, and we can hear you very well.
Okay, hi everyone, this is Joanne from USM. So today, actually, I'm very excited to share the latest CPG guidelines that we have just launched last month. So if anyone is interested to have a soft copy, you can actually download it in the Malaysian CPG website. Okay, it's about 140 pages. So if you are a little bit lazy to look through, then I'll just briefly just guide you through in the next 1 hour about our latest CPG, and hopefully we'll be able to finish on time. Okay, so let's start. So what is psoriasis? So psoriasis is basically a very chronic inflammatory disorder with a very high disease burden. Okay, it doesn't just affect the skin, it also affects the joints, the cardiovascular system, and also the metabolic syndrome. So apart from physically, it also have a heavy impact on the psychosocial and also economical burden. And globally, it affects about 2 to 3% of the population worldwide. Okay, so at present, we do not have a cure yet for psoriasis. Therefore, psoriasis is a lifelong condition that we need to treat. So with the latest CPG, there's actually a lot of new treatments that has been added on to effectively treat the psoriasis. So we start with how does psoriasis actually presents. So in basic, psoriasis has 5 phenotypes. Okay, the common one that we usually see is the plaque psoriasis, also known as psoriasis vulgaris. There's also the gutted, right, which is like the raindrop types of psoriasis. Then we have the inversus types over the flexural region, which can commonly mimic fungal infection. And there's also the pustular form and also the erythrodermic form. So where does psoriasis usually happen? So normally it usually happens at the extensor region, like the elbows and the knees, but it also can affect other areas like the umbilicus, the back, and it sometimes can cause a special site involvement. Basically means areas that the patient cannot hide, and it usually associated with high psychosocial impact. So example would be like the scalp, the face, the flexural area, and also the genitals. Okay, not forgetting the palms, the soles, and also the nails. So apart from the skin, it also affects the nails in up to 50% of the patient. So it can be something more like just mild pitting to a more severe form like the crumbling and the tracheonychia. We can see sandpaper, rough-like nails. And sometimes it also can cause nail bed symptoms like the splinter hemorrhage, subangular hyperkeratosis, salmon patch, and also the splitting of the nails on the nail bed, which we call onycholysis. So apart from the skin, the nails, it also affects the joints. So it can cause small joint involvement, it can cause large joint, and it can also cause the axial joint involvement. Okay, so if we do not treat this properly, it can lead to severe mutilation, which we call arthritis mutilans. And apart from the joint, it also affects the tendons, which we call enthesitis. And even the digits can be sausage-like, which we call dactylitis. So you can see psoriasis affects almost everywhere. So how do we diagnose psoriasis? Psoriasis, basically, there's no one test that can confirm this is a psoriasis. It is still mainly diagnosed by clinical, so by history and physical examination. And sometimes, if we are still not sure the atypical cases, we can use skin biopsy to help to guide us. So next, what are the aggravating factors of psoriasis and what causes psoriasis? So these two can sometimes be the same thing or it can be multiple. And if you can see here, the top two, these are genetic and family history. These are the non-modifying factors. But for the rest are basically the factors that can be modified, which we should focus on when we are treating our patient. So for example, we need to advocate stop smoking, reduce alcohol intake, reduce weight, okay, reduce the stress, avoid skin trauma, treat any active infection, avoid certain drugs that can trigger psoriasis, avoid sedentary lifestyle, and of course, environmental factors do play a role, for example, air pollution. So what are the comorbidities associated with psoriasis? We need to know this because we're not just treating psoriasis, we need to treat everything that comes with it. Okay, so psoriasis has been shown to be associated with cardiometabolic disease because it do share some genetic and molecular pathway. So if this psoriasis is not treated well, the inflammation signals can subsequently lead to hypertension, fatty liver, diabetes, obesity, and dyslipidemia. And all these will subsequently contribute arteriosclerotic disease. Again, you can see here this nice graph. There are multiple shared inflammatory cytokines among psoriasis and the other comorbidities. So cardiometabolic disease, apart from that, would be your GI. So for the GI, apart from fatty liver, inflammatory bowel disease is also associated with psoriasis. For psychiatry, depression, anxiety, even personality disorder. And for others would be like malignancy. Here, I just like to highlight cutaneous T-cell lymphoma has a high hazard ratio as high as 6.2%. And then for the other disorder would be like sleep apnea and also chronic kidney disease. So for the comorbidities, whenever we see a psoriasis patient, we should always screen them for the cardiometabolic disorder, psychiatry disorder, and also the other comorbidities. So now we go on to the psoriasis severity. So whenever you want to treat a psoriasis, we need to first know what is the severity of the psoriasis. And then we subsequently compare it during treatment. And there are many ways how do we assess severity. Okay, from the doctor's point of view, there's a doctor's outcome, physician outcome. So the common one is your body surface area. And then for the more sophisticated one, you have the PASI score and also the physician global assessment. And then for the patient one, it can be as simple as itch score, pain score, and even the DLQI. So just a quick recap, body surface area, if it's large, you can use the rule of 9 like the burn patient to calculate the estimated body surface area. And if it's just a small area, you can use the rule of palm. So using the patient's palm involving the fingers. So one palm is actually about 1% of the patient's body surface area. Okay, and then now comes the PASI score. PASI score is basically used among the derms when we are treating the patient and comparing it with the systemic agent effectiveness. So apart from the body surface area, it also looks into whether how red is it, how thick is it, and how scaly is it. So a higher score means a more severe condition. Okay. Then we have the physician global assessment. So this is basically in a 5 category from clear, minimal, mild, moderate, severe, and very severe. And the DLQI basically is a questionnaire of 10 questions released into the impact of psoriasis on the skin symptoms, the daily activity, how it affects the work, the social life, relationship, and also treatment. So you can see here, the higher the score, the more impactful it is. So previously, from the old guideline, it is psoriasis is basically divided into 3 categories: mild, moderate, severe. But now we have simplified it to just 2 categories, either a mild or moderate to severe. Okay, so for the mild one, it's everything 10 and below. Okay, these are basic candidates. They are indicated for topical treatments. And then for the moderate to severe ones are basic candidate for systemic. And we're talking about systemic, basically means phototherapy and also the systemic agents. So apart from your BSA more than 10, PASI more than 10, DLQI more than 10, we also look into special areas. So special areas, even though it might not be 10%, but it can be very impactful to the quality of life. So this will be like the face, the palms, the soles, the genitals, and also the scalp. And of course, if the patient already failed topical, they are indicated for the systemics. So now that we know how severe our patient is, then we start our treatment. So after starting the treatment, then we want to know how good is our treatment? Is it effective or not? Do we need to change or step up the treatment? So we need to have a treatment goal. So the treatment goal is basically a shared decision between the patient and the doctor on what they want to achieve. So from the guideline, you can see here, we're trying to achieve a better BSA of less than 3%, or a PASI score of 5 or less, or a 75% improvement in the PASI score. And for the DLQI, we're aiming for minimal life impact, which is 5% and below. So this can be actually assessed initially at least 12 to 16 weeks after we start the treatment. And once it's stable, we can actually reassess it back every 3 to 6 monthly. So now that we have known the severity, let's go on to see the treatment. So for treatment, we always start with non-pharmacological before going to pharmacological. So for the non-pharmacological, so if the patient asks what to pantang, so we basically need to know that the patient have to aim for ideal body weight. So this can be done either through diet or exercise. So apart from the smoking cessation, psychotherapy also do help. So now we go on to the pharmacological treatment. So pharmacological treatment, we divide into topicals, phototherapy, and systemic. So for the topical treatments are basically the most common treatment for psoriasis. So for the mild condition, it can be given as monotherapy. But for the moderate to severe one, you can combine it with the other systemic agents or phototherapy. And the success actually depends on the adherence of the patient to the topicals. And a good adherence often starts with a good education. When we see the patient, we need to tell them what is the treatment about, how to apply, how frequent, where to apply, when to step down. So sometimes it can be so many treatments that the regime can be so difficult the patient do not want to follow. So always try to simplify the regime. Okay, so now we'll go through one by one. So we have moisturizer. So moisturizer basically restores the skin barrier and it improves the penetration of other topicals. So we have many types. This is just among the few that we commonly see: aqueous cream, liquid soft paraffin, and also white soft paraffin. Okay, then we have steroids. So topical steroid, there are many types. It's very important to know which is mild, moderate, potent, and very potent. And from here, I just want to highlight there is a limit for the potent one. So no more than 4 weeks of limit of the continuous use. And for the very potent one, try to limit no more than 2 weeks of continuous use. Okay, so the patient commonly can apply once a day, but can go up to as high as twice a day. Then we come to vitamin D analog. So vitamin D can be in combination with the corticosteroid. So the beta-methoxam dipropionate is actually a potent steroid. So this one, you only apply once a day. There are many types, the ointment form, the gel form, and even the foam form. There's the original one and the generic ones. So here, I just want to highlight there is a limit of 15 grams per day, which is about 1 tube per day limit, or the BSA of less than 30%. So we are basically trying to avoid the hypercalcemia and vitamin D toxicity. So once this is already well controlled, then we can actually taper down to a proactive dose of twice weekly. So this actually allows a sustained application of this vitamin D analog, reducing its side effect, but still able to prevent relapse of psoriasis. Then we come to calcineurin inhibitors. Basically, there are two types, tacrolimus and pimecrolimus. One is an ointment, one is a cream. This one, I just want to highlight, always tell the patient, it's not a daily dose, it's at least a twice daily dose. Okay. Common things, the side effect is basically local irritation. So basically avoid over areas that are actively inflamed. Okay, so these are steroid-sparing agents and are usually used for the face and also the flexural area when you are worried about steroid side effects. Then the other topicals that we have is the tar-based, like our Sebita shampoo, which is a wash-off, and also the leave-on topicals. Yeah, I just want to highlight that we need to advise patients to avoid, especially during the first trimester. Okay, ditranol very can cause local irritation. Commonly, most of the hospital no longer have it. Okay, whereas for salicylic acid, basically, I just want to highlight need to avoid no more than 20% BSA because there's risk of salicylism. Okay, so now that we have gone through the conventional topical, so what is new in the topical treatments? So the new one is topical small molecules. They are basically targeted therapy that is a good alternative for patients who are unresponsive to conventional topicals. Okay, they are basically in 3 classes: the phosphodiesterase 4 inhibitors, the aryl hydrocarbon modulators, and the JAK inhibitors. So among the ones that I list here, the one that I highlight here, basically the ones that FDA approved is only 2, which is roflumilast and tapinarof. So how good is it? There is actually a network meta-analysis on topical small molecules. And so far, the best on the top is the tapinarof, which is your aryl hydrocarbon receptors. So despite it is effective, it does come with a higher adverse event. Roflumilast is safer. And on the third is JAK inhibitor, which is your ruxolitinib. So this is a summary of the drugs. So you can see here the 2 that is approved, which is tapinarof and roflumilast, are both cream. They are applied once a day. Tapinarof only approved on adults and above, and roflumilast for 12 and above. There is no BSA limit, and the common adverse events are basically local site irritation and URTI. Crisaborole is actually not approved for psoriasis yet, but it's approved for atopic dermatitis and available in Malaysia. So this one is a kind of ointment that is applied twice a day, and you can give as young as 3 months old. There is no surface BSA limit, and again, similarly, the local site irritation is a common side effect. For ruxolitinib, again, still used off-label, not approved yet. But for the AD and vitiligo, you can give as young as 12 years old, and there's a BSA limit of 10 to 20% respectively. So now that we have gone through the topicals, let's go on to phototherapy. So phototherapy, the most common phototherapy we use is narrowband UVB. So this should be considered as a first line, and we should be offering it at least 2 to 3 times per week. So if this is done in hospital setting, then patient needs to be able to commit to the regular follow-up for this treatment to be effective. Okay, and I just want to highlight nowadays, here the advocate skin cancer should be screened if the patient is taking PUVA more than 200 sessions, or narrowband UVB more than 500 treatments. And among the contraindication for phototherapy, I just want to highlight that it should not be given concomitantly with oral cyclosporine and also others like azathioprine, MMF, and oral tacrolimus. Okay, now that we have finished the topical, the phototherapy, let's go on to systemic treatment. So for systemic, basically it's divided into conventional and the targeted one. And the targeted one is divided into biologic and oral small molecule. Okay, for the conventional treatments, there are basically 4 types. And among the 4, in Malaysia, we only have 3 types, which is the methotrexate, cyclosporine, and acitretin. So you can see here, for this conventional treatment, they do need quite a regular investigation to be monitored. Okay, so you can see here before the treatment, the one tick is the ones that you need to take, and then subsequently follow-up is need to repeat it almost every during every visits. So for the methotrexate, you can see here the focus is on the full blood count and liver function monitoring. And for the cyclosporine, apart from the blood pressure, you need to regularly check the renal profile, the fasting lipid, and not forgetting the urinalysis and calcium, magnesium profile. And then for the acitretin, it mainly is to monitor the liver function and also the fasting lipids. Okay, so for methotrexate, you can see here on the left side, methotrexate looks like the right side this folic acid. So very important to tell patient that methotrexate has to be taken once a week, ideally on the same day every week. And other days you take folic acid. Try not to mix up as they look very similar. Okay, if the patient takes it and have a lot of GI side effect, then there's also another option, which is the IM or the subcutaneous form. So here, I just want to highlight if the patient is on methotrexate, they need to be at least 3 months of cessation before safe for conception. Okay, this is how acitretin look like. So it basically looks like a capsule antibiotic. Okay, in 2 types, they have the 10 mg or the 25 mg one. Okay, so here I just want to highlight this one. You need to be very careful for women of childbearing age. Okay, they need to stop at least 3 years before safe for conception. And apart from that, blood donation is also contraindicated while you're on the acitretin. So next is cyclosporine, also looks like a capsule. Okay, this one mainly the limit is 2 years of continuous use. After that, you need to rest it temporarily before you can restart again. So always avoid the sun, no concomitant phototherapy, and those with previous PUVA is also contraindicated. So you can see here, if the patient is pregnant, they can use cyclosporine, but in breastfeeding, it is absolute contraindicated. Okay, now we have finished the conventional, then we go on to biologics. Okay, biological treatment are basically bioengineered proteins or monoclonal antibody. So these are actually very large proteins that act extracellularly, and they act on immune mediators or the receptors. So they're basically injectable. As you can see here, these are all the pictures of the biologics. They are injectables. So if those patients are scared of injections, scared of needle, then this is not something suitable for them. Okay, so they're basically divided into 4 classes. The TNF-alpha is the oldest, followed by IL-12/23, IL-17, and IL-23. And the one in the book one are the ones available in Malaysia. Okay. So how good are they? So there's a Cochrane network meta-analysis. They look at how good the patient is achieve PASI 90, which is a 90% improvement in their PASI score versus the adverse event. So you can see here the ranking, the best is IL 17 and 23, and this is followed by IL 12, 23, TNF alpha, and then followed by small molecules, cyclosporine before placebo. Generally, biologic have less side effect compared to the conventional. However, there is some common side effects like injection site infections, reactions, flu-like symptoms, and even things like UTI, fungal infection, particularly the IL-17, and other symptoms like arthralgia, headache, diarrhea, and nausea. Okay, so biologics are preferably prescribed by dermatologists and is indicated in two types. Either if you are moderate to severe one, already intolerance or contraindicated or fail the conventional, or it can be straight as a first line for severe disease when clinically judged that the treatment success cannot be expected with the conventional treatment. So a bit like the conventional. So initiation, there's a long list of screening to do, but subsequently the monitoring is less frequent. Usually about every 6 monthly, you can consider repeating full blood count, renal and liver function, and a yearly TB screening. Okay, so you can see here what are the selection biologics for various comorbidities. So across the board, it is actually very well tolerated from various comorbidities. Just want to highlight, if you have inflammatory bowel disease, avoid interleukin 17. If you have advanced heart failure or TB, then avoid TNF alphas. Okay, now that we're finished with the biologics, then I'll go on to the oral small molecules. So oral small molecules are very small, less than 1 kilodalton. Whereas the biologic is very big as more than 150 kilodalton. So since they are so small, they can actually enter the cell and target intracellular enzymes. So this will modulate the nuclear transcription and cytokine production. So basically, there are two that is approved, apremilast and deucravacitinib. So apremilast is available in Malaysia. It is a phosphodiesterase 4 inhibitor, whereas the deucravacitinib is a tyrosine kinase 2, TYK2 inhibitor, or also a kind of JAK inhibitors. Okay, so if you can see here, how effective are they? Again, from the Cochrane network meta-analysis, the more towards the right side, the better it is. The more towards the left side, the less effective it is. The higher it goes, the more side effect. The lower it goes, the least side effect. So you can see here in the black dots, so apremilast is one of them, and deucravacitinib is also in the middle. So these two are comparable with our methotrexate. So how does apremilast look like? So basically it comes in boxes of a 2-week dose. So the final dose is 30 milligram twice a day. And because it does come with some GI effect, so the initial initiation of the treatment, you need to titrate it. Initially from 10 milligram OD and subsequently up titrate it to a 30 milligram BD dose. So things to watch out is it can cause weight loss. So it can be a good thing for obese patient, but it can be a bad thing if the patient is anorexic. Okay? So beware if the patient have depression, suicidal ideation, or anorexia is basically contraindicated for this medication. So in Malaysia, we have the generic one called the Aprazole. It's only available in 30 milligram tablets, so only approved for the adults. But actually, there's another one, a 20 milligram dose for children, which I'll talk later. Okay, how about deucravacitinib? Deucravacitinib also fixed dose, 6 milligram once a day. Things to highlight is they do cause reactivation of herpes simplex, herpes zoster, and also acneiform rash. So if the patient have chicken pox in the past, we are worried about the herpes zoster. So we can actually advocate the herpes zoster vaccine, which is a Shingrix vaccine, which is good to be initiated before the treatment. And again, because this is a new drug, it's only approved for adults. Okay. For investigation, so for deucravacitinib, more or less like the conventional, you need to do the whole list. Okay, and then periodically you might want to consider repeating the liver function, fasting lipid, and also TB tests. Whereas for apremilast, it's different. Apremilast, you hardly need to do any blood tests. Okay, it's optional. So for those patients who doesn't want injection, cannot come for regular blood taking, apremilast is something to be considered. Okay, so if the monotherapy fail, then you need to consider combination treatment. So you can combine any of the group that I've mentioned just now. The only thing to avoid is phototherapy with cyclosporine. And for the other systemic agent, if you want to combine, just need to be a bit more cautious. Okay, now we come to special population. So as we know, psoriasis can often subsequently develop arthritis. So basically, this type of patient, you need to screen annually at least for any symptom of joints. Okay, and if they have psoriatic arthritis, then we look into what is the domain that is involved. If it's involving the axial joints, then we need options that is preferred will be a TNF alpha or the IL-7. And if the skin is very severe, then the preferred will be IL-17. Okay, if it involves other peripheral joints or the enthesitis, dactylitis, then you can consider the rest. Okay, and for the conventional ones, methotrexate do help the joints and the skin. But for the others like sulfasalazine, leflunomide, these are mainly good for the joints, but not so good for the skin. Okay, and then now we come to pregnancy and lactation. So overall topical treatment that is safe is your moisturizer, low to mid potency steroids. And the one that need to be a bit cautious is the vitamin D analogs and calcineurin inhibitors. The rest we need to avoid. Avoid salicylic acid, tar, and also ditranol. For the phototherapy, avoid PUVA. Okay, but for the narrowband UVB, it is generally safe to be given, but for the pregnant ladies, they are prone to get folate deficient. So for these patients, if we want to do phototherapy, we should supplement it with folic acid and also face shield to reduce their risk of the melasma. Okay, how about systemic? So you can see here, for systemic, there's only one agent, which is cyclosporine, that you can give for pregnancy, with caution. But after pregnancy, lactation is contraindicated. Whereas acitretin, methotrexate, and even the oral small molecules are all contraindicated for pregnancy and lactation. And then for the biologics, so basically, the preferred option is the TNF alpha, particularly the certolizumab pegol. So this has good safety data for both pregnancy and lactation. It's just that unfortunately we don't have it in Malaysia yet. So other biologics that we can consider, you need to use with caution. And things I want to highlight is that if the mother is on the biologic for at least beyond the 16 week of gestation, then we need to delay the live vaccine in newborn up to 6 months. How about pediatrics? So pediatric, basically all the topical you can use. Phototherapy mainly is to avoid oral PUVA in those less than 12 years old. And then for the systemic, mainly if the patient is already like a female childbearing age, then you need to be cautious, especially the acitretin. Okay. And then for the oral small molecule, if we have the 20 milligram one, is actually approved as young as 6 years old. Okay, otherwise, deucravacitinib still not approved for kids. And for the biologics, you can see here mainly all are approved as young as 4 to 6 years old, except for IL-23. Okay, now we go into cardiometabolic syndrome. So if the patient have advanced heart failure, avoid two things. Avoid cyclosporine and avoid anti-TNF alphas. So anti-TNF alpha has a negative inotropic effect, which can worsen your cardiac failure. And then for the ischemic heart disease and dyslipidemia, also avoid two things. Avoid cyclosporine and acitretin. Both can worsen the cholesterol. How about CKD, chronic kidney disease? So for cyclosporine, it's a big no across the board. Okay, for methotrexate, acitretin, avoid it in severe CKD. For apremilast, if the eGFR is less than 30, then you want to omit the night dose. So it will only be half dose, which is an OD dose. Biologics are generally safe and no renal dose adjustment. Okay, how about chronic liver disease or those with viral hepatitis? So generally, you need to co-manage it with the gastroenterologist. Okay, and among the preferred one will be apremilast, fumarate, which is not available in Malaysia, and then the newer biologics like the IL-23, followed by 12, 23, and 17. So this has a low minimal hepatotoxicity and are usually low in reactivation of viral hepatitis. So a bit of caution if you're going to use acitretin and TNF alpha, since these two have some moderate risk of hepatotoxicity. And the ones that we need to avoid is methotrexate, cyclosporine, and also deucravacitinib. All right, so the next is the HIV. So HIV often can present severe and atypical psoriasis. So we always need to manage it together with our ID physician. So things I want to highlight here is if we are suspecting Kaposi sarcoma, then we need to avoid PUA. And for the systemic treatment, the preferred one is the acitretin and apremilast. And for biologic, generally we can give to HIV patient, provided that the HIV is well controlled, where the CD4 is more than 200 and viral load is undetectable. And then how about those with depression and suicidal? So two things to avoid. Avoid apremilast, avoid brodalumab. And always manage with the psychiatrist. And for the neuro, especially those with demyelinating disease, apart from co-managing with the neurologist, we want to avoid TNF alphas. How about cancer? So if the patient have current cancer or previous cancer less than 5 years old, 5 years, then we want to avoid cyclosporine. Okay, the rest are generally between strong recommendation and weak recommendation. And then how about surgery? If the patient with psoriasis on systemic going for surgery, so generally acitretin can be continued without stopping. Then we look into the other treatment. So other treatment, we need to see the risk of infection in the surgery. Is it a low risk one or is it a moderate to high risk? So low risk basically means patients that doing procedures that is sterile, it does not reach into the respiratory tract, the GI tract, and also your GU tract. So if it is a moderate to high risk case, then we can discuss with the surgeon. If the surgeon is very confident, we can continue the systemics. But if they are worried, we can actually stop it 3 to 5 half-life before the op and restart it back 1 to 2 weeks post-operation. And particularly highlight will be the joint replacement. If the joint replacement, particularly a total knee and total hip replacement is to be done, then the recommendation is to stop TNF alpha at least 1 dose interval for all. How about vaccination? So ideally, vaccination should be done before any systemic treatment. But however, if the patient is already on the systemic, generally inactivated vaccine can be given without any interruption. But for live vaccine, be careful. It is safe for those of acitretin, apremilast, and fumarate, but contraindicated for the others. So if you want to give them, then we need to stop at least five half-life before and restarted it back 2 to 4 weeks after the vaccine. Okay, and again, the newborn with the mothers already on the biologic beyond 16 weeks of gestation, we need to delay live vaccine to 6 months. And this is our BCG. Okay, so I'm moving towards the end of my slides. So this is a summary of how we manage psoriasis. So in the primary care setting, okay, so when you're seeing a psoriasis case, always check up and see whether does the patient have any arthritis. If there is psoriatic arthritis, please refer also to the rheumatologist. If the patient have comorbidities, we need to manage them adequately. If not, we can refer it to any subspecialty that is managing it. Then we look into the psoriasis. When we look into psoriasis, always see the severity first. If this mild case, you can initiate topical treatment. If it's moderate to severe, please refer to the dermatologist for systemic treatment. And while waiting, please initiate topical treatment. Okay? So once it is initiated, then you need to regularly monitor and see, is it effective or not? Is the treatment goal achieved? If it's not achieved, you might need to step up or refer. And then, so this is basically a summary recap of what I've mentioned just now, the treatment modalities for psoriasis. So for the mild case, you have topical treatments like the moisturizers, steroids, vitamin D analogs, salicylic acid, ditranol, and calcineurin inhibitors. And hopefully coming in, we can have the topical small molecules, which is the tapinarof and also the roflumilast. And for the moderate to severe ones, okay, then we have 4 things to consider. Phototherapy, where narrowband UVB is the first line. Then systemic, we have the conventional one, methotrexate, acitretin, cyclosporine. If it's not suitable, we can consider oral small molecule like apremilast and hopefully in the future, deucravacitinib. And then we also have biologics. So biologics, if we feel that it's very severe, then that the other conventional treatment will not be able to successfully treat it, we can actually start the biologics straight away. So when to refer? So please refer to the dermatologist if you're not sure of the diagnosis, or refer it urgently if you're seeing someone with erythrodermic state or the generalized pustular type. If it's severe one, more than 10%, you know you need systemic, or already failed topical treatment, or with special site involvement with high psychosocial impact. And not forgetting to refer rheumatologists when we're suspecting psoriatic arthritis, or if you're not sure how to manage it adequately. And with that, I thank you.
Thank you very much, Dr. Joanne, for a very comprehensive review of basically everything about psoriasis. So that was very comprehensive and very clear, I thought, the lecture. We have 2 questions, so I will just read it out for Dr. Joanne. The first question is from Dr. Kavitiran. Can we use low-potency steroid like hydrocortisone for the face?
Yes. So, good question. Thank you again. So basically, if you are looking into the face where the skin is very thin, you can use mild to moderate potency steroid. But you need to be very careful, okay, especially over the eye and other oral area, as these are the areas that are very high likely to get steroid side effects. So this area, if you have the option, please consider the steroid sparing agent like calcineurin inhibitors. Okay.
Okay, well, we are on the topic of steroids. I think before I read out the next question, maybe Dr. Joanne, can you share with us how do you counsel patients who has got steroid phobia? Nowadays, a lot of patients do not want to use steroids, right? So how do you advise them?
Yeah, so this is a very common thing that we encounter in the skin clinic. So sometimes patients is not responding because they are so scared that they are refusing to apply adequately. So usually what I advise them is that as long as it's not in the eye area, away from the oral region, so basically you apply it until it is, you no longer see any inflammation, it is smooth. When you close your eye, you touch, it's as smooth as your original skin. Then you can consider tapering off to probably initially from OD dose, you can go EOD, then subsequently taper further every other day, then maybe weekends. And not to worry too much because when we apply, okay, sometimes if we over apply, it can cause skin atrophy. But if you were to stop applying, the skin actually regenerates back like the hair or the nails. So basically, the skin will thicken back. So it's not something permanent. So I always try to we need to sort of reduce their phobia and always actively ask them, are they worried about this side effect before condemning that, okay, this treatment is not responding, has already failed the steroid treatment. Yeah. Sorry, Prof. Yeah, muted.
Another question, which is along the same line, how common is steroid withdrawal syndrome?
Okay, steroid withdrawal, I would say quite common. So sometimes the patient, when they have been applying it for a long time, yeah, so they will feel that steroid withdrawal needs topical, is it?
I think it refers to topical, yes.
Yeah, there are two things. So some patients will feel that after applying for some time, they lose the efficacy of the steroid. And some patients, when they're applying, it improve, but when they stop it, it tend to flare again. So basically, again, we need to counsel the patient. Basically, psoriasis is something chronic and lifelong. It has ups and downs. And basically, we will have to learn how to teach them how to up titrate and how to down titrate according to the psoriasis disease activity. So when it's already very well, smooth, already no longer inflamed, try to step down. And when you feel that it's already coming up again, then you need to start out the treatment. So always try to if those patients like the hotspot area that they tend to have easily flare of the psoriasis, then sometimes instead of just stopping, we can actually advocate proactive treatment. So proactive treatment is actually a very good treatment, like we treat our atopic eczema case. So let's say if a patient is already well controlled, do not stop abruptly, always taper down, and at least have a weekend, twice a week treatment of topical steroids to keep the psoriasis at bay.
Yeah. Thanks, Dr. Joanne. I think the term steroid withdrawal syndrome is not very well defined in terms of scientifically or clinically defined. The term itself is commonly used by the general public, right? But in terms of when we are talking about the problems with steroid, the terms that has been very well recognized is tachyphylaxis, like Dr. Joanne mentioned just now, and also rebound. So there are strategies and ways on how we can overcome tachyphylaxis and rebound, and I think Dr. Joanne has just described it very well just now. Okay,
Yeah,
moving on
probably
to
maybe the person asking also worried about the oral one. So basically the thing that we are worried about is the oral systemic steroid. So if you accidentally give it and the patient is already of course when the patient is on the steroid, it's going to be very good. But if you stop it, the psoriasis tend to rebound back, and sometimes it's even more severe than the original form. So sometimes if we manage to catch this patient, it's always good to try to slowly taper the systemic steroid until zero. Yeah.
Yeah, and in the first place, do not give systemic steroids for patients with plaque psoriasis.
Yeah.
Because it's going to be a nightmare to taper it off. Okay, the next question is, hello doctor, I would like to ask if we can mix steroid cream with aqua cream for eczema patient, and both eczema and psoriasis patient.
Yeah, so the short answer is yes. So like I said, it's always good to combine, multi-modal treatments for the best effective and the best outcome for the patient. So the moisturizer actually helps to improve the skin barrier. It allows better penetration of the steroid. So if you can combine it, why not, right?
Next question is about why is anti-TNF to be avoided in treated TB? Does it cause reactivation if it is treated?
Yes, a very good question. It is not an absolute contraindication, but TNF alpha has been shown to cause reactivation of TB, even though they have been treated or they have latent TB in the past. So, among all the biologics, TNF alpha, we need to be very careful. So if you have other options available, then try to steer away from it. But if you have no options available, ideally we want to treat it first, then only start the anti-TNF alpha, and always monitor it at least every year. And just to highlight, the reactivation of TB in biologics, it's not the pulmonary. The common one is extra pulmonary. So don't just look into the chest, also look into other symptoms.
Yeah, the anti-TNF is not absolutely contraindicated for people with current or previous TB, but we want to avoid it because we have other options, a lot of other options, right? Because TNF alpha has the highest risk of all the other biological agents towards TB reactivation. Okay, the next question, Dr. Joanne, how do you teach patient on methods of topical application?
Okay. First of all, you need to know where are the sites involved. Okay. If it's on the scalp, I try to give something that is gel or liquid. So the consistency. So if something over the body, then we look, is it something very thick and dry, or is it something very mild? So the mild one, you can consider creams, and then the very dry, very thick one, you can consider ointment. And how frequent to apply? Like I mentioned, a steroid not more than twice a day, but a moisturizer you can apply in between as frequent as you want. So basically, another thing is the amount. Okay, so for the steroids, we have this fingertip unit. So basically, when you're using the tube of the steroids, when you apply it from the first interphalangeal joint, first interval until the tip of the finger, that is one fingertip unit. So the one fingertip unit can actually cover 2% of the body surface area of the patient. So you can roughly gauge if the patient only have 2%, just tell them to apply one segment of the tip of the finger, and you can apply it evenly over the whole lesion without worry about excessive use of it.
The fingertip unit guide is available on page 109 of the CPG. Okay, next question from Dr. Benedict. Let's see what Dr. Benedict wants to know. Based on the guidelines, is there a must-follow stepwise approach to choosing between anti-TNF, anti-IL-17, 23, 12, small molecule, or JAK? Other than their indications for axial, stroke, skin, or joint, or dosing schedules and price. Example, use anti-IL-17 drugs first before IL-23 or vice versa. Okay, so basically I think what he wants to know is how do you choose between all the different types of biological agents and also the JAK inhibitors and small molecule?
Okay, first of all, I need to know what is available first in my center. Okay, so doctor factor means we need to see is it available or not. Be comfortable using it. Okay, then patient factor. So patient, I will look into whether is it very severe, or is it moderate, or is it mild. So for the severe ones, then we look into does it associated with other comorbid. Do we want something that is fast, or do you want something that is slow and sustained? Does the patient want injection, or the patient doesn't want, there's neither phobia, they want something orally, and whether can the patient come regularly for follow-up. And of course, price is always something that we need to consider when we're talking to the patient. Okay, because as you know, the new agents, even though they are very effective, they are very expensive, and not everyone have the financial support for it. So if they do not have the options, available, or they're not suitable, or do not have the financial support to have those treatments, then we basically need to try to play around with what we have, what we can offer the patient, and try to get the best for the patients.
Okay, next question is from Dr. Nur Izrina. So she asks, when we mention severe CKD for the drug contraindication, do we refer to eGFR of less than 15?
Sorry, one more time.
When we mention severe CKD, when we use the term CKD for the drug contraindication, do we refer to eGFR less than 15?
Okay, so basically, if according to guideline, any eGFR less than 60, you need to be cautious already. Anything more than less than 30 is already considered severe.
Okay. What are the good advices we can give for patients given vitamin D analogs? Any specific amount of applications, and is it applied daytime or nighttime is better?
For the vitamin D, as I mentioned, you need to avoid the sun, right? So it is best applied at night. Okay, and since there is a maximum limit of one tube, which is 15 grams per day, so overall it comes to about 100 grams per week. So these are basically something to consider when you're trying to limit the BSA for the patient, how much to use. Yeah.
Okay, I think we have quite a number of difficult questions. So the next one is for conventional systemic agents. Could you tell more on the pros and cons of combination, sequential, and rotational therapy versus monotherapy?
Conventional.
Sequential and
Sequential.
rotational.
Okay, so sequential and rotational are basically more or less the same. So last time, when we don't have the newer agents, we tend to rotate around the conventional treatment for those moderate to severe psoriasis. So as we know, like cyclosporine, there is a limit of 2 years. So in between, you can rotate it with something else like acitretin or methotrexate. So this basically helps to basically reduce the side effect of continuing using a single systemic agent long term. Okay.
Okay, I think we have 3 minutes more, so maybe one last question. For severe flare of the face, if no improvement with low to mid potency topical steroids, stroke calcineurin inhibitor, can we give a short-term high potency steroids on the face?
Okay, so if according to guideline, the highest you go is more moderate potency. So moderate potency example would be like your probetasol, butyrate, okay, or the betamethasone, 1 in 4, 1 in 10. Yeah, these are the moderate ones. Try not to go to potent. Okay, anything more than that is basically off-label.
All right, I think that's all the time we have today for the question and answers. It was warming up quite fast. Usually that's how it goes. People have more questions towards the end. So thank you very much, Dr. M, for the very comprehensive lecture and the very insightful responses to all the queries from the audience. I'll pass the screen back to Dr. Uy.
Okay, thank you, Prof. Dr. Adavia and Dr. Joanne, for the comprehensive and very interactive talk today. So on behalf of College of Physicians of Malaysia, I thank you both to the chairperson and the speaker, and we will meet all of the audience next week again. Thank you.
Thank you. Bye.